Gilles Montalescot from France, and he will present the results of the Atlantic study, in-ambulance versus in-cath lab administration of ticagrelor in STEMI patients transferred for primary PCI, a randomized double-blind trial. Gilles.
Dr. Valentin, Dr. Antman, ladies and gentlemen, the Atlantic study is a strategy study. This is a design of the study. We recruited 1,862 patients, actually, with ST elevation MI within 6 hours of chest pain, and these patients were randomized to be treated with ticagrelor in the ambulance at first medical contact or in the cath lab at the time of the angiogram, same drug, same dose. We had two co-primary endpoints, and the study was powered for both endpoints: ST segment resolution, more than 70%, and TIMI flow grade 3 on the angiogram before the procedure. You have on this slide the median times that we had in this study, and you can see that from the onset of symptoms to the diagnosis of STEMI, we had a median time of 73 minutes, which is very short, and we dealt with early presenters in this study. The median time difference between the two study groups was 31 minutes when we expected 1 hour. Again, rapid transfer, rapid treatment, a very effective system in general in the 13 countries which participated to this study. The global ischemic time was 159 minutes in this study. We performed a platelet function sub-study, which is available in the manuscript, and actually we observed the largest difference between the two groups 1 hour after PCI. The two co-primary endpoints are represented on this slide, and there was no difference between the two groups for coronary perfusion, whatever we looked at, the electrocardiogram or the TIMI flow on the initial assessment in the cath lab right after transfer. We started to see the effect on the electrocardiogram after PCI, as shown here, where there is a difference which is almost significant for ST segment resolution. The data were very consistent across all the pre-specified subgroups for the primary endpoint of ST segment resolution, except one subgroup where there was a highly significant p-value for interaction, and this subgroup is a group of patients receiving morphine. As a primary endpoint of ST segment resolution was actually significantly improved in patients who did not receive morphine when ticagrelor was given in the ambulance. When we looked at clinical endpoints, we observed at the time when we had the largest difference in terms of platelet inhibition, we observed a significant reduction of stent thrombosis with a p-value of 0.0078 at 24 hours. Actually, up to 5 days, all the events occurred only in one group, the group of patients receiving ticagrelor in the hospital. The difference was preserved at 30 days and was significant with a reduction of stent thrombosis with pre-hospital administration of ticagrelor, as you can see here. If we put this data into perspective with the large Plato study, you may remember that in Plato, ticagrelor reduced stent thrombosis significantly against clopidogrel. And in this study, ticagrelor was administered in the hospital. Actually, we observed exactly the same rate of stent thrombosis in Atlantic in the group receiving in-hospital ticagrelor, roughly 1% of stent thrombosis at 30 days, 1.2%. But there was a reduction which was highly significant with a pre-hospital administration of this drug. We looked at safety with as a Plato definitions, but also with other sets of definitions for bleeding, and all the data are very consistent, whatever the set of definition. And there was absolutely no difference between the two groups for major bleeding. Major bleeding was not different, minor bleeding was not different, the combination was not different within 48 hours or up to 30 days. So the conclusion is pretty simple for this study. Pre-hospital ticagrelor administration a short time before PCI in patients with ongoing ST elevation MI is safe, but does not improve pre-PCI coronary reperfusion. It may, however, reduce the risk of stent thrombosis after PCI at a time when we observe also an effect in the platelet function substudy and on the electrocardiogram when we measure ST segment resolution. Thank you very much.
Questions to Professor Montalescot? Yes. There, do we have a microphone? Yeah, you can, Shelley, you can
I'm ready.
Start.
Shelley Wood, heart.org. Can you speculate on the mechanism? I think I understand, but why would this reduce stent thrombosis later?
It's related to the timings that we have in this study. I was impressed by how fast the patients called, how fast the ambulance went to the place, how fast they transferred the patients. And if you remember, for example, the on-time 2 study, where we had very short delays, this time it's even shorter than in on-time 2. It's a kind of world record of transfer of patients in terms of timing in this study. So we have an oral drug. It takes some time to get the effect. The onset of action is rapid, but not that rapid. So what we observe is the effect after PCI on platelet function, on the electrocardiogram, and on stent thrombosis. Most of the events occurred within the first 24 hours.
So would there be any reason to try this in countries where the symptom to balloon time is so much longer?
It's an excellent question. Actually, in this study, we had 2 groups of patients. The largest group of patients was primary transfer, so the diagnosis was made by the ambulance crew. The electrocardiogram was made by the ambulance crew. The pills were given by the ambulance crew on site. But there was 1/4 of the population who presented in the emergency room of a non-participating hospital. This hospital had no cath lab, and the ambulance had to go to this hospital and randomize the patients for a secondary transfer.
We have one more question there, maybe.
And we observed the same finding in this group.
Yes, please.
Dawn Powell from Cardiovascular News. Actually, you did ask the question I was going to ask, but one question I was going to think about. I mean, what were the stents used in the study? Were they all second-generation drug-eluting stents, or were they different, or bare metal?
We had the majority of drug-eluting stents, 51%, but we had all sorts of stents, and there is no difference according to the stent used.
Any more specific questions to Professor Montalescot? We could finally open the floor for any remaining question you have.